Now we have the next speaker.
Dr. Sruthi R. She is a consultant in cataract and glaucoma at Giridhara Institute, Kochi. She'll be teaching us regarding Capsulorhexis and the hydroprocedures.
Good morning to all. I'll be dealing with capsulorhexis and hydroprocedures in small incision cataract surgery. Capsulorhexis is a very critical step in cataract surgery, and it influences the surgical as well as the visual outcome. The advantages of continuous curvilinear capsulorhexis over the previous capsulotomy procedures are that it resists the anterior capsule radial tears. It helps in safe nucleus rotation and cortex aspiration. It helps in the stability and centration of the intraocular lens. And in cases of PC rent, it helps in sulcus placement of IOL. The prerequisites for a good capsulorhexis, the first thing is the visibility. So for visibility, we should have a good focus and centration of the microscope. And the cornea should be clear. There should be adequate mydriasis. Either we can use a retroillumination for viewing the anterior capsule, or in cases where the retroillumination is not available, like in cases of a hard nucleus or in mature cataracts, or if there is a vitreous hemorrhage, we can use trypan blue dye. The anterior chamber should be adequately filled with cohesive viscoelastics, and we should not press the wounds inadvertently, allowing the visco to escape through the wounds. The size of the rexus is also very important in small incision cataract surgery. The central 6 mm is the safe zone, but the size of the rexus can be titrated according to the size and the density of the nucleus. Adequate mydriasis again helps us to make rexus of required size. In this video, we can see first the air bubble is injected and the anterior lens capsule is stained with trypan blue uniformly. And then after washing out the dye, viscoelastic is injected into the AC to maintain the AC. And then first initial nick is made in the anterior capsule, then a triangular flap is raised. Then the rexus is started and the anterior capsule is torn in a circular manner using the cystitome. We can either use a microrhexis forceps or Uttarata forceps for the same. And the folded capsular flap should be always made flat on the anterior lens capsule. It helps in control over the rexus. In cases of intumescent cataracts, since the intralenticular pressure is very high, there is high chance of getting a rexus extension. So it is always safe to do a double rexus. In case of a double rexus, first a small central capsulorhexis is made. Then after that, either we wash out the liquefied cortex or we express the flaky cortex. And after that, the opening is enlarged into a normal sized capsulorhexis for the nucleus removal and IOL insertion. Here we can see first a small nick is made with the cystitome, and the small capsulorhexis is completed with the help of a microrhexis forceps. We can see the liquefied cortex leaking, and microrhexis scissors is used for the nick of the rest of the capsule, and the second rexus is completed with the help of microrhexis forceps. So this helps in control over the rexus. And in cases of intumescent cataracts like this, it is always better to put a dispersive viscoelastic over the capsule so as to get a flattened capsule. The complications of rexus, first one is small rexus. It causes a difficulty in prolapsing the nucleus and difficulty in inserting, especially a rigid IOL. And the chances of zonular dehiscence will be very high trying these two steps in a small rexus. Rexus extension is common in mature cataracts, but it can occur in any type of cataract, especially in the beginning stages, and it may even result in a wraparound tear of the posterior capsule. In this video, we can see it is an intumescent cataract. On attempting a small rexus with the microrhexis forceps itself, the capsule rexus got extended. Then a sclerocorneal tunnel is made with a crescent, and the entry into the anterior chamber is done with a keratome. And then a nick is made at the rexus extension point, and the capsulorhexis is completed with the help of Utrata forceps. And then the nucleus is dialed out and it is delivered out of the scleral tunnel. And the posterior chamber intraocular lens is inserted into the bag. Then coming to the hydroprocedures, hydroprocedures helps in freeing the nucleus from the capsule and it helps in prolapsing the nucleus out of the bag. It is called hydroprolapse and it lessens the zonular stress. It can be either hydrodissection or hydrodelineation. Hydrodissection is the separation of cortex from the capsule and it should not be done in a pressurized anterior chamber. So it is always better to wash the viscoelastics from the anterior chamber before hydroprocedures. Hydrodelineation is the separation of epinucleus from the endonucleus and it is done in the paracentral zone. And after completion of hydrodelineation, we can see a golden ring and it is especially useful in posterior polar cataracts. Here I am going to show two videos of hydrodissection and hydrodelineation. In hydrodissection, we are injecting the fluid just below the rhexis margin and the fluid goes under the nucleus. And in hydrodelineation, we are injecting the fluid into the substance of the nucleus and it helps in separation of the endonucleus from the epinucleus. And at the end of hydrodelineation, we can see the golden ring. The complications in hydrodissection. Incomplete hydrodissection leads to difficulty in rotating the nucleus. There can be intraoperative capsular block syndrome, which occurs when there is large amounts of fluid accumulation behind the lens nucleus during rapid hydrodissection. And it can lead to posterior capsule rupture also. Thank you.
That was excellent, Dr. Sruthi.